Good morning, everybody. It looks like there's still some people trying to connect. Let me give everybody another minute or so.
Just a couple quick announcements on my end before we start the day. You might start to see a few changes to some supplies here and there. Some of them are just temporary with production and shipping issues during COVID. Our pack company, Cardinal, has had some issues getting some products in. And so some of the subs might be that you might see a green bowl instead of a blue bowl in your PDS pack. Some of these are just temporary. One of the permanent ones is the company that we used to get our aseptos and our earbulb syringes. That company is no longer making that product. So you are going to see some packs without it. And there will be extra on the shelf. You might have to pull one, and we'll get them back in the PDS packs once we determine the suitable alternative. But the company that had been making the ones that were in a lot of our packs is no longer making them. And so they're having to get us a substitute. If there's anything that is a functional or different change, then that will go through the STMs first. And we'll let staff know if there are other items that are going to be pulled or missing from packs. You might see some labels on the outside of a pack that a pack has been assembled without something. So just pay attention to the labels on the outside of your PDS pack for things that might be missing. You probably have already seen the bright orange labels about the ChloraPrep that was recalled. There were certain lots of ChloraPrep that were recalled. All of the packs were labeled that have that lot number. It's not all ChloraPrep, it was just certain lot numbers. And so if you receive one of those packs with the bright orange label, just throw the ChloraPrep out, get one out of the supply cabinet in the room. We've been very busy. We've been very tight lately. So thank you to everyone for working really well together. Communication is key when we're really busy like this. And so just a shout out to everybody for helping each other out. for the good teamwork, the good communication. Just a quick little read. My daughter gave this to me the other day. She had to write a little letter last year and I totally forgot about it. And she had given it to me and she reminded me that I didn't read it. So just a kind of good feeling this morning. So she said, "Dear VCU OR, I appreciate everything you are doing, especially right now. You're working really hard and I don't think you get the appreciation you deserve. You have many COVID patients on top of regular patients and I can imagine it's difficult, but you can get through it. I hope that your families and your friends are doing well and don't have COVID and won't get it. The OR does many great things with and without COVID, and I think it's magnificent. Please continue doing what you are doing, and I hope COVID will be over soon." She's in 6th grade or 7th grade, sorry. They had to write a letter to people that are their heroes. And so she wanted to recognize the OR staff because she knows that we're kind of the behind the scenes people and don't often get recognized for what you do every day. So thank you from me, thank you from my daughter, and keep up the good work. ORSAs, you were going to see a second draft schedule up. I'm sorry to have to do that, but we had several people who had school schedules that for the summer classes that came up, and they needed to work some off shifts. So it might mean that I pulled you off of an off shift back to a day shift. So I'll post that today and I'll highlight any shift changes so that you can review that and make sure that those are okay prior to us putting it in the book. And please, if you have any concerns on any of the changes that I've made, please let me know so that we can get it corrected. And I think that that's all I have for the morning.
Hey, everybody. Okay, I'm here. I'm trying to also help out. I think there's a couple people that were trying to find us. So let me double check. Let me see. Maybe. Let's see. All right, I'm going to go ahead and get started. So, let me double check. I think, Shanae, are we recording? I just want to double check that real quick too.
Yeah, I am.
Cool, thank you. All right, so good morning, everybody. We just went over announcements. We're going to do a quick quality April review. We're going to go over surgical count update regarding packing specifically. Also, there's a couple updates to our most recent Foley kit. So I want to go over some of those things with you guys. And then also do a brief positive language review. So some of this I might move through kind of quick. Quality review, IUSS rate 0.9%. So good job. There were some things discussed during huddle this morning about loaner trays and things like that. So it's still a work in progress, but we're doing really good keeping that IUSS rate low as possible. Overall hand hygiene for the department is 82%. We've got listed out here the units with the most opportunities and then also the roles with the most opportunities. So please continue to be diligent with your hand hygiene practices. If you see somebody who maybe missed an opportunity, then let them know. Let's see. For safe surgery checklist audits, again, remember to discuss your x-rays, implants, equipment during the pre-brief and or timeout. If it's not indicated, just simply say that. But at least you've mentioned it and we know that it's an intentional, we don't need that for this procedure type thing. Debrief compliance is improving. However, there's still plenty of room for opportunity. The biggest, well, not biggest concern, but one of the bigger concerns is with our specimen management. So please continue to be diligent with reviewing specimens, confirming with the surgeon, you know, not only what is it going to be called and what's the order, but whenever you get those labels printed, make sure that you're checking that label, checking it on the actual container for the specimen or bag if it's something that can't fit into one of those containers. So just make sure that you're doing each safety check for that. It's more than just filling out a piece of paper. Really, we don't want to have to do the piece of paper, but the intention was to try to have that be the prompt to make sure that you line by line, item by item, go through and get that checked off or do those safety checks. Cerner documentation, please remember to fully complete that pre-op checklist. We are auditing that. So whenever you go do your pre-op checklist in PSU or PACU, wherever, make sure that you update the need for the x-rays and implant verification there. Also, the site marking or blue banding must be documented. So if the pre-op nurse comes in and finishes their assessment and leaves before the attending's made it in there, but then since you've been in, you see that they've been marked, you can absolutely update that piece. Even though it's not technically in your section, you can still update that piece just to make sure that it's recorded. And we know that the patient was in fact marked before the procedure. Attire, so we're continuing to see behind the red line, lots of jewelry, bracelets, rings. Remember that we have to have the cloth caps covered with a disposable, and then beards cover. And I know throughout the day, those things kind of start to sag down. So just try to remember to pull it up every once in a while around your beard and even with your caps to make sure that your hair is covered. Let's see. And then clip back, we should have a clip back in every OR. If you don't, or if something breaks, please notify leadership as soon as possible so that we can either get a replacement or get the one fixed. But if you do clip in the operating room, you should use that clip back. As always, clipping in pre-op area is most preferred. Let's see. All right. So surgical counts. The policy is not live on our site right now with these updates because we wanted to do the education for it. I'm also going to double check with the surgeon side to make sure that all of those individuals have been made aware. But you're going to see some email reminders and things like that, flyers and stuff go up. But because of serious safety events, we always kind of go back and review policies and see how we can update any procedures or the policy to help make things more clear and better for our patients. So a couple of definitions were added to the count policy. And essentially we separated our intentional packing of countable items or things that the patient are going to need to come back to the OR to have removed. So we separated those out from packed dressings. So those are things that are not intended to require the patient to come back to the OR for removal. So we didn't want to put an all-inclusive list out because we know sometimes certain situations come up for a particular patient and we don't want to, put ourselves in a corner. So we don't have an all-inclusive list. Some critical thinking conversation with the surgeon can occur to work through it. And if anybody has questions, then absolutely escalate it if you have any issues. Somebody's drawing on our slides. So therapeutic intentional packing, again, countable sponges and other miscellaneous items that are packed into a wound, which will require the patient to return to the operating room. Such items include syringes, chokers, the elastic sheets, lap pads, and Raytec. Packed dressings, again, not intended to require them to return to the OR, such as vaginal packing and rectal packing. So this is what the policy reads now for that therapeutic intentional packing section. Use of any form of non-radiographic or non-RFID detectable sponges and dressings is not recommended for use as a therapeutic packing. So Curlex, essentially, think of Curlex. We don't want them to pack Curlex into a big open belly. If the surgeon deems no other alternative is available, the following measures should be followed. So the integrity of the roll should not be altered, so they don't want it to be cut. If the integrity of the roll is intentionally compromised, then there needs to be a measurement included in documentation so that we can make sure when it comes out, we know how much is supposed to be there. And if you remember, we had SSE about with a piece of gauze that was unintentionally left in a patient. A visible portion of the packing should remain outside of the wound and easily identified. Nursing documentation and protocols for intentional retained sponges should be followed. So if they do use a Curlex, you would follow that orange band protocol. Upon removal, the roll is inspected for integrity and then documented in that record. And then measurement would be included in removal if there's any disruption of the integrity identified. So again, this is our orange sheet, just as a reminder. It's documented for any incorrect, if therapeutic packing is used, then your counts are incorrect, so make sure to document that in the chart. Our tracking form is completed with all the information of what's packed, and then make sure if the patient is having multiple procedures and being packed and repacked, to complete the bottom portion of their form, and then if they're packed again, start a new form. We want to keep all of those together for each of the patients. Your armband, making sure that that is placed on the patient as well. Let's see, the amount and types of sponges or other items. If it's a miscellaneous item, make sure that that's communicated during patient handoffs and documented in the record. The surgeon should be communicating to the patient and or family representative for the plan for removal. If you're using RFID detectable items, then you don't need to wand because we know it's going to be a positive wand. Our goal is to have a negative wand. So you don't have to use that until you've unpacked and you think that you have nothing in there, then you definitely want a wand. And then document any of these occurrences in the SI system or PSN system. So our packed dressings, again, types of packed dressings include vaginal, rectal, any kind of wound packing like Curlex or iodoform. Ensure that those packed dressings are documented and communicated throughout the next phase of care. And you're going to document those in the dressing section of your chart. No change to the throat packs, but I put this in just as a reminder to keep all the packing stuff together. So you can have that to refer to when Shawnee sends out the slides. Final count procedure and documentation. So this section was also revised to address the use of the RFID detectable vaginal packing and wanding procedure. Previously, it was that at the conclusion of a case, if the patient was in lithotomy, you didn't complete your final counts, sponge counts or wands until the patients came out of lithotomy. However, if we do that with our RFID vag packing, then we're going to have a positive wand, and we don't want that. So for procedures that are performed in the lithotomy position, the final sponge count and wanding are conducted immediately prior to placement of any RFID detectable vaginal packing. So at the conclusion of the case, there's intended for nothing to be in the cavity at all. You're going to do your counts, you're going to do your wand. If the surgeon needs to place the vaginal packing, then they would do so. And then immediately after placement of that packing, the legs need to come out of the stirrups. That way you're not leaving it easy access for a resident to grab a Raytech and put something in. things like that. We're trying to prevent that. So if cases do not involve that RFID detectable badge packing, then the field is wanded after legs are removed from stirrups. So it would be the same process if we don't have any of that badge packing. Again, this includes any vaginal procedures, vaginal deliveries, perinatal rectal cases. And then for other cases, your RFID wanding is going to be performed at skin closure. If there's a case without a wound, like your tonsillectomy, then the wanding is performed at the end of the procedure once you've removed that throat pack, for example. Just another snip about RFID wanding. Speaking up for discrepancies, making sure that before closing the wound, the surgeon performs or directly supervises the wound exploration for any unintentionally retained items. Before closing counts just prior to the closure of a secondary body cavity, and then prior to closure of a cavity, and then when wound closure begins. So there's multiple counts that you're doing, and that's how you should document them in your record. If you do multiple counts as you're closing these layers, which you should be, that's how it should be listed out in your documentation. Otherwise, it looks like you did one initial count and one final count. Anytime you do change of personnel count, things like that, document that in your record as well. So just a reminder there. With specifically the vaginal packing piece, GYN is working on a vaginal sweep, vaginal cavity sweep process map, I guess we can say. And then they're also working on a separate form and I believe armband. That stuff has not been vetted through their committee just yet. So once that actually comes to be practiced, we'll bring that back to the group so everybody can be made aware as well. Okay, let me see. I don't see anything in the chat. All right, so I'm going to keep going. Foley kits. We had an upgrade to our Foley kits. All of the 14 and 16 French urinary catheters are getting this upgrade. What you're going to see on the front is there's the CHG wipes, and then there's a second pair of sterile gloves. So this is what we have now, current state. Future state, they're starting to trade it out, and you're going to see the pictures a little bit different here. So for, I guess let me go back. I thought I had another slide in there, sorry. So for adults, before you place a Foley, you're going to get the patient in position, and then you need to do a wipe, pre-wipe with pre-cleaning with the CHG wipes. And in the kit and also in the slides here, you're going to see the steps to do that. For pediatric patients, so they're saying anybody under the age of 18, you're not going to use that CHG wipe, but we're going to have these purple ready bath wipes in the environment. We're connecting with Robbie to make sure that they get stocked, but they still need to have some sort of pre-wipe, pre-cleaning before we do the Foley placement. Also, once you do your pre-wipe and you start to get the rest of your kit set up, that gives the wipe and for adults that CHG time to dry, which is good. That's what we want. So there's 2 CHG wipes in this orange pack. This is on like the back outside of the actual Foley kit, so you don't have to open it to reach in to get in it, to get these wipes out rather. Just flip the package over and pull them out from the back. And again, it's got the steps right here in that pouch to show you how to actually use those wipes. So you're going to do that pre-cleaning kit with non-sterile gloves once you get the patient in position. Let's see. You want to do that CHG cleaning before the under the buttocks drape is placed. And then you only want to use the CHG on intact skin as well. So just to keep those in mind. Oops. Skip something. Oh, so this is for females. You're going to have the 2 wipes This kind of goes through, go down each thigh and then down the middle. And then for males, again, each side, and then how to wipe on the penis and scrotum down the middle. Try to keep an eye on time too. So the first layer of the tray, they have a lot more pictures of words in this kit, so it's pretty cool. But they're gonna show you, remember to do hand hygiene, patient teaching pamphlet, right? Under the buttocks drape, shiny side down. You're gonna put that in with non-sterile gloves. You also want to be careful, try to not touch all the inside of that drape, and then take off your non-sterile gloves and discard. Your second layer of your tray, just a reminder, and the reason why there's 2 pair of gloves, sterile gloves, is because you should have a 2-person insertion. The second person not only is observing to make sure that there's no breaks in sterility or aseptic technique, but also they are going to have sterile gloves on so that they can help retract anything that needs to be. Sorry, I don't know why it's skipping ahead. So remember to do your hand hygiene. It does come with these what am I trying to say? Your hand hygiene cleaner. Why can't I think of the word? Anyway, sanitizer. Thank you. So she did say if you use that entire pack, you're going to be waiting a long time for your hands to dry. So only really just use half of it. Or if you're like me, put that in your pocket for later and just use the pump in the room. That works too. These gloves are kind of a medium size. So if you know you have bigger hands, then you probably just want to get another set of gloves, but from the cabinet. But again, there's your reminder for 2-person insertion. It can be an unlicensed person. The idea is that they're going to be assisting and kind of under your direction. I did question again about the med students, and essentially they really only want nurses to do it, but it's not written in policy anywhere. So I'm just throwing that out there. But again, if a med student's doing it, then the nurse needs to be the one to assist and keep your eye on them. And then make sure to document both people in your record as well. As we move to Epic, so this is something that right now in iView, the rest of the house documents and has to put that second person in. As we move to Epic, that's going to be the practice. So please just try to get that into kind of your habit as well. Inside the kit, there's your sterile water and your lube. There's reminders, and it looks just like this. It's huge. Reminders as far as not pre-testing the balloon. And she said when you pre-test a balloon, when it's deflated, it doesn't quite mold back to the catheter as it was when it was first sterilized. And because of that, it can be traumatic while you insert it. And so they find that it's best for the patient and decreases any trauma as you're inserting to not pre-test it. There's also a reminder here, and there's your measurement here, a ruler, to lubricate 3 to 5 inches of the catheter. And this is that insert kind of blown up there. So remember, 3 to 5 inches of lube should be on that catheter. But it goes step by step, has the reminders in there also, and it's on one of the flaps of the kit. So I'm not going to walk through all of this. She did reiterate the use of the window. The purpose of that, which a lot of people didn't know in the session, is that it's creating a barrier between your GI and your GU. And if you're doing something and accidentally touch the patient, not where you're trying to go, you want them to be touching this drape instead of anywhere else on their skin, and then you're potentially introducing E. coli into their bladder, which is not what we want to do. However, she said, even if you don't use the whole window for females, if you keep it folded in half and just kind of put it up against their bottom, at least that's some kind of barrier, because she knows that we all know that it kind of gets in the way. But let's see. They did talk a lot about the drainage bag and the tube placement. So the clip that's on the bags, it's not to clamp the tube of the Foley. It's to help keep it in place on the patient's bed. So don't pull that off if you're placing the Foley and they're going to keep it after surgery. Try to leave that on the tube. And you don't want any kinks, but this is not a kink, it's just a loop. We want the urine to be able to drain passively. So if you think about it, and I know there's some graphics in here. Oh, I kind of went through all that stuff already. There's some graphics in here. So this is the kickstand that's on the Foley bag. So use that to help improve drainage and make sure that there's not a kink right there where it connects to the bag. There's some pictures here about like where it kind of compares the tube to a roller coaster. So I'll go over that in a second. Prepping the bag, she talked about in the sterilization process of Foley bags, and really this is kind of any bag, not just Medline, but there can be an airlock. So to alleviate that, if you unhook the drainage port and open that up, pulls the bag and separate it. And as you do it, you can tell that there's like a lot of suction in there. Open that up to introduce some air. That way the urine can drain easier. So just try to remember that as well. This is what I was talking about, and it shows this is essentially the patient's bladder. So all this urine is sitting in here. We've got, it looks like a roller coaster. We don't want it to look like the Rebel Yell at King's Dominion. This urine is just sitting in here collecting bacteria. It's not actually getting to the bag. And then all that urine is just sitting in the patient's bladder. So make sure that the urine can drain to gravity. Again, we've got that roller coaster loop here. We don't want that. How this kind of loops here allows for the urine to drain a little bit easier. And actually, let me go back. So one of the things that they talked about was placement of the securement device. So think about it also with that placement for males, because all of their pieces and parts are up higher. If it's attached to their upper thigh or outer thigh, the catheter, the urine can still drain pretty freely out of that. If you have a female, pieces and parts are between the legs. If you put that securement device and secure the catheter on top of the thigh, you're creating an incline right whenever it comes out of the patient's body. And that's pretty difficult for the urine to get out of. So she suggested and said that really the best place for females to secure the catheter on the inner thigh. Granted, we do have to keep in mind any kind of, if it's a bigger patient, any type of opportunity for pressure injury with that, but just something else to consider. So the infection prevention department did a lot of work for these kits, and there's going to be more to come. You're going to see some, again, the purple wipes and kind of some difference in the kits moving forward. And we're still going to have all the different urology kind of build your own kits that we currently have. So now I'm going to move on to positive language. How do I get this slide off? If I stop sharing and then reshare, maybe it'll work. I think I got it. Okay. All right, positive language. So, where am I on time? Oh, there we go. Does anybody have any questions? Do you want to put it in the chat about any of the stuff that I just went over? I just want to make sure. All right, I don't see anything. So some keywords at key times. We changed the presentation up a little bit for we're going to use it for orientation. So there's a couple examples of the actual keywords at key time slides, but it doesn't cover every role probably that's on this Inservice right now. So we have the pocket cards in the education office, so you can absolutely come by and get those to get the information for your actual role. I just left a couple in here as examples, but let's see. So we're going to go over the impact communication and perception of, how things are communicated has an impact on the overall patient experience. Understanding the use of keywords at key times, and then how to use the HEART service recovery model. So what do our patients want? To be treated with dignity and respect, helpful team members that are easy to talk to and approachable. They want to be listened to, their concerns to be taken seriously. So we need to absolutely communicate those things to them with both verbal and our body language. Our VCU team is everyone, so this covers everybody in surgical services. We've rolled out positive language for PARs, everyone in the main operating room, and we're continuing to roll it out. We're going to roll to, we've started EVS, and we're going to move on to sterile processing as well. So this is going to cover everybody, endoscopy as well. The framework that we used was based off of AIDIT communication framework, and that stands for acknowledge, introduce, duration, explanation, and thank you. So we used that framework to build the keywords at key times. As a healthcare provider, we want to avoid surprises and set realistic expectations for the patients. And then also having accuracy and frequency in communication with patients is key with making sure that they understand what's going on with them and can help relieve some anxiety that they have. As example, I know it doesn't happen so much with us, but let's say maybe you're walking through the hall. There's been plenty of times in Maine that someone comes to the wrong elevator bay. Maybe you need to walk them down to gateway. So talk to them as you're walking with them, explain, kind of what's going on and where they are and things like that. And just remember that they don't, this isn't something that they do every day, and they're probably overwhelmed. So just try to help kind of ease their anxiety. But also similarly with team members, we've got a lot of new team members in the environment, a lot of learners. So as you're talking to them, maybe about certain skills, processes, just remember that, again, they're learning and this isn't something that they do every day. So you should have some patience with them. And again, it's probably an overwhelming experience for them too, even though they might not be freaking out on the outside, they may be on the inside. So just have some patience with them. Let's see. Using the communication framework helps to build confidence. It takes some guesswork out of the care and the teamwork. It reduces anxiety. Definitely displays some STAR service behaviors there. And it should be used each time that you interact with a patient, family, or visitor and team member, rather. So we do survey our patients. We use Press-Ganey surveys. It reviews the rating of the hospital, likelihood that they would recommend the hospital. There's specific questions about communication with nurses, the house staff, and physicians, the environment, the treatment that they received, things like that. So we do send the survey out, and leadership reviews those results as well. And really, it's because of this survey that Perriott pulled together a patient experience committee. So there's a lot of things going on in that committee to help improve the overall patient experience. And one of the things that came up on some of the surveys was about communication that the team members were having with patients and visitors. So that's why we have the positive language training, to make sure that everybody's aware that the way that we say things are, body language and things is absolutely being picked up. by our visitors, even if it's not something that's directly for them, but maybe they're within earshot of something that they've reported out on some of their surveys. So just to keep that in mind as well. These are some of their specific questions, again, talking about being treated with courtesy and respect, talking about safety with COVID, the responses to questions, things like that. Things with their care about, information, their education that they got, especially post-op for like nausea, or if they're bleeding, things like that. And then overall facility and treatment. So if they're clean, if the team is helpful, things like that. But we know that it's more than just patient satisfaction. As team members, everybody wants to be treated with respect, wants to work on a good team that is helpful. If they have concerns or issues, they want to be listened to and heard. So we know that having better communication and those techniques, it will lead to less safety events. A lot of the serious safety events have some sort of communication piece tied into it, especially again with our specimens and that verification as an example. So some of the behaviors and techniques, I'm going to go over phones first. And essentially, this slide is talking about the difference between interactions versus transactions. We want the interaction is talking, looking, active listening, and sharing and having an engaged conversation. And that's not only over the phone, but even in practice. Again, I know I keep beating on the specimen thing, but having engaged conversation, both parties actually focused on what's going on, can lead to less events, serious safety events, or any misses, things like that. So we want to transform transactions into interactions. We want that engagement. So for phones, we actually do have institutional guidelines about calls being answered within 3 rings, not having more than 2 transfers, being sure to ask if you can place the person on hold, or take their name and number if you need to call them back. Making sure that when you're picking up the phone or answering, have a greeting, don't rush. You want to be respectful, speak clearly, provide your location, your unit or your organization. I know for us, probably even more specifically, your operating room, whatever you're working in that day. State your name also. Just some key things there. Don't rush the conversation. Don't be rude to the person on the other end. I know there are definitely some times where you just need to get your point across and move forward. And I get that. We've got emergency situations, but you don't have to be nasty or anything like that. So just keep that in mind. Person on the other end is a person. So in person, smiling whenever you see someone, making sure to have eye contact, make eye contact with them, and acknowledge others with a greeting. Again, introduce yourself with your name and your title and what your role is or how you're going to help. One of the things that came from the Hospital Patient Experience Committee was the 10-5 rule. So within 10 feet, you want to make sure to have eye contact, make eye contact with them. And then within 5, you give a verbal acknowledgement. So that's just something to keep in mind. So this piece is where we would, for the other presentations, we went into more of the actual keywords, phrases for each roles. So I only kept a couple examples in here. Words are free, but it's how you use them that can cost you. And our words have the power to heal, comfort, but also most definitely hurt. And we don't want to do that. So the work group that came up with these keywords, phrases, identified some specific words that we should incorporate into our daily language in conversation with team members and patients. Help, assist, comfort, privacy, clarify, safety, and respect. So each role within PERIOP does have, again, one of those keywords cards that goes into some phrases And those were built with individuals from that specific role input. They provided input and we made those. Most of them are things that are current issues or problem areas, and we wanted to really focus on those to be reminders. So please come to the education office and pick up your card if you don't have one. As an example, the ORRN has quite a lot of categories here, so not every role's card is going to have every single category. It just kind of depends on your functions. But as an example, so responding to questions, I'm happy to help you with that. Speaking to patients or even other team members, what other questions may I answer for you? I'm sure that learners would appreciate that invitation to ask more questions. And then be sure to follow up and follow through if there's a request or something. So as an example for conversations pre-operative with the patient, because we respect your privacy, the curtains are going to be closed. Intraoperative, for your comfort, you will be provided a warm blanket and padding for your arms and legs, things like that. I know there are some other ways that people communicate with patients and some kind of phrases that they use with all patients. I think it was Kim Cooper that gave me that NASCAR pit stop analogy for patients once you get into the OR, which is really nice. But what that does is you're communicating to the patient, you're telling them what's happening to them, and you're trying to help explain, so that they can like breathe a little easier, know what's going on, that kind of thing. I know Sam talked to me about some things too that he says, especially in pre-op, that he wants the patient to know about, safety, that we're doing stuff, we're providing safe care, that kind of thing. So I know that some of you guys, most of you probably are using some of these kind of in your own way, but these are some extra tips and lines that you can use. So this is our example for transporters. Again, for your safety, we will confirm your name and date of birth often throughout your care. We do have some patients that are like, don't you know who I am? Why do I have to answer this every time I talk to somebody new? So we're just trying to get that into their minds as soon as possible, that for your safety, we're going to be asking you this multiple times throughout your care, things like that. So. All right, so managing up refers to instilling confidence by telling others of your abilities, a fellow team member's abilities, or maybe even a department. So things like this include, you would enjoy the cafeteria because they offer a variety of food choices and have multiple areas that you can sit and relax and enjoy your food, things like that. You want to make sure that anything that you say is the truth. So if you're trying to manage up and say something about a surgeon or a team member, you want to make sure that whatever it is true. We don't, want to just say something nice for the sake of saying it, and then the patient asks the next person about it, and they're like, "No, that's not at all. I don't know who they're talking about." So just make sure that they're true. And again, there's some additional questions here on that, or examples rather, on that slide. So sometimes we do have situations that create concerns or conflict, and we have to have patience when dealing with situations. If somebody's upset, do your best to de-escalate the situation and try to assist the individual. So we do have a service recovery model, which is resolving concerns with heart. So having a heart means to hear, empathize, apologize, respond, and think. And this is really where we live that motto of our caring service begins with me. You want to make sure that we do everything to salvage that experience for the patient or family or team member. We do have some drink vouchers for family members if there's something that comes up, to try to help get them off the floor, let them go grab a drink, kind of calm down a little bit, things like that. But it's more than just passing out a voucher and moving on. We want to actually recover that situation and flip that patient experience from something negative back to positive. And we want to show them that we care and that we want to improve their experience. It's the same thing when working with upset team members. You can pull this heart recovery model in and follow other STAR service behaviors. So make sure that you're actively listening, listen to them the way that you want to that you want to be heard. You need to hear them. Don't make excuses, become defensive, things like that. Don't interrupt them. You want to empathize. So find ways to identify with their situation. State that concern back to them so that they know that you're trying to understand and understand. Apologize for the experience and don't just throw someone else under the bus. Just take that on. Know that maybe it wasn't you, but just take that on, take that in, and apologize for that patient. They don't want to hear that so-and-so did such and such. They just want an apology. Respond by telling them what you're going to do to try to fix it. If you can fix it, great. If not, then state what you're going to do to help address that problem. And then thank them because they're giving us the opportunity to improve the experience for them, but then also future patients and family members. So remember to be sincere. Don't just monotonely, well, I'm sorry, or anything. Don't give them attitude. Be sincere. And if you need help, if it continues to escalate, then pull in leadership. Use your chain of command to get some backup. This is an example here about a patient arriving for surgery with multiple family members. I know with COVID, we've have some visitor restrictions, and they're upset because they can't go be with the patient. So just think how you would respond in that situation. So using heart hearing, so nod your head to let them know that you're listening, make that eye contact, empathize, sorry. I understand your frustrations, let them know that, apologize. I'm sorry for this inconvenience, and then respond and thank. All right, so some of the ways that we communicate are verbal and nonverbal. So you want to be sincere and understanding and respectful and talk in an appropriate tone. And then ensure that you're making eye contact, have an inviting posture so that they're not afraid to come and talk to you. Look interested. If you can, get on their same level so that you can make eye contact with them as well. Communicating without heart looks like eye rolling, being rude, not making eye contact or looking away, looking at your phone, things like that, having any kind of negative facial expressions, just saying no, but not explaining why. Definitely want to, I know a lot of people say that they're working on their facial expressions, so it's good that you realize that and that you're working on that, but try to keep that up. So good job. And even though people, some have said it's good I have a mask on, but it's like you can see a lot with your eyes. That's all you need to see. So just keep that in mind too. On stage versus off stage behavior. So this example is because if you've ever been to Disney, which I have not, but I've heard a lot. If you've ever been to Disney, all of the characters are as if they're on stage. Just imagine if you're there walking around with your family and you cut the corner and Mickey Mouse is standing there holding his costume head, smoking a cigarette and yelling at Cinderella for something that happened this weekend. I think that would probably set you back a little bit. It may, it definitely would change your experience, and it might change even the perception of Disney. So think of us being at work as being on stage. We're a huge place. There's a lot of little nooks and crannies. A lot of times that people could be just around the corner, and even though you can't see them and you may think that you're whispering low enough, but other people can hear you. So just keep that in mind as well. The other person could be a patient or a family member, or maybe it's a team member. Maybe you're upset with that team member. So everybody needs to vent, and I get that. You need to go to an appropriate place. And absolutely, if you have an issue with someone, as always, go talk to them about it first. They may not even be aware. So just do those things to try to facilitate teamwork and positive communication. Let's see. As a reminder, don't have personal conversations out in the open. Definitely don't have conversations about, patients or patient information out in the open. We have consult rooms in PSU. I have basically walked people over, residents and attendings with patients or families over to those consult rooms so that they're not just doing it out in the hall. So just kind of remember that too. Don't use your cell phone just out everywhere. Make sure to go to an appropriate area for those as well. And then you should not be wearing earbuds out and about. That is a huge safety risk. So keep that in mind too. All right, so next steps, practice these behaviors, both the communication piece, you know, verbal, nonverbal, STAR service behaviors. If you don't remember those, it's available on the intranet, and coming up, you're gonna have to give some examples for evaluation. So that'll be a good refresher, but make it your own. You know, we don't want this to be like you have to pull your card out and read from it whenever you talk to somebody. Make it your own. Everybody's, you know, really creative and can do that too. Support one another, have each other's backs, and then make sure to also recognize each other. We've got starburst, leaves, offer tulips or daisies, things like that. Everybody likes a pat on the back, and we don't do that often enough. So just remember to do that. So where am I on top? I got a few minutes. If anybody has questions, I want to thank everybody for listening. I got my chat up if anybody wants to say anything. I'll ask, how did you guys like the Zoom meeting versus Teams and the QR code? I'll do a survey for that. It seems to have worked pretty well. There may be times though, if you know an STM is the host of the meeting, then it may be on Teams. But I think for if education is going to host it, then it probably will be a Zoom.
Well, I like the Zoom. I think it takes a little confusion out of making sure you're in the right teams, because we've had issues with that where people are logged in but not logged into the correct meeting. So I think it took the confusion out of where to go this morning.
Okay. Does anybody know who the, if you saw the QR code, who that picture is? I don't see anything in the chat. Maybe nobody cares. That's fine. It made me happy. It's my new favorite thing, putting a picture in the QR code. Anyway, all right, that's all I got. I don't see any questions. Everybody have a good day, and go have a good day.
Thanks, Erin.
Erin.
Thank you.